In terms of capturing patient-reported outcomes within the clinic setting, we've been doing some exciting work, particularly in the Kirkland Clinic and in the 1917 Clinic, where we actually have panels of patient-reported outcomes that are of interest to the specialty that we can capture during the process of routine care. These would include things like, if I'm a pain researcher, I might do a basic signs and symptom screening, and depending on which signs and symptoms are more exacerbated, I might bring in a specific pain measure, or I might bring in a physical quality of life measure, physical functioning measure, different types of things responding to the patients rather than just taking a sheet of paper and doing a review of systems. Rather, they do it electronically, and we bring in other domains that are relevant to their care that day based on what they answered and what's going on. We've been implemented that in several clinics, in the 1917 clinic, in the Kirkland Clinic, and we're moving into pediatrics, which presents a very intriguing issue because all of a sudden you have one session, part of the questions are to be answered by the caregiver, and part of the questions are to be answered by the patient. So it's some interesting things about where you are and who's holding the device at that time that we've been looking at. Here's some specific examples. When people are using their patient-reported outcomes, when they're filling them out, there's actually a notification functionality when they complete an assessment. So if you complete an assessment and it says that you are suicidal, in the 1917 clinic, you'll have pages that go immediately to a psychologist and to a social worker. They coalesce with the person watching the screen that day. They get the room number where the patient is at, and then a protocol is activated where people go into the room and do a full assessment for safety and have a recommendation before the healthcare provider ever gets to the room. So by the time I get to see that patient, I have a psychologist waiting for me in front of that room that tells me, this is what's going on with your patient. These are their current plans. This is my recommendation to optimize their care today because they are suicidal. We've used the same type of notifications to help us detect intimate partner violence, which is a tremendous problem. I mean, estimates in the survey in 2006 sort of put it at 25 to 26% of women will experience intimate partner violence at some point in their life. In our population, we have a lot of same-sex couples. There's also intimate partner violence there, though there's much less literature about it. So we use an intimate partner violence screen as part of our practice to do a better job of detecting who is at risk, who is suffering this, and once detected, we activate a response protocol to make sure that we can ensure the safety of that individual. These are two examples in practice of how we use patient-reported outcomes to take better care of the people that we're privileged with seeing. Another application that we do as well is we do study recruitment off of patient-reported outcomes. So a patient can be feeling something, they say that they're depressed, and rather than me having to have a research team member go and ask those questions and figure things out, the patient is doing it as part of the routine care process. Because our mission as part of an academic medical center is both educational, patient care, and research. And if we use technology wisely, we can capture data that can be reused to potentiate each one of those missions. Patient-reported outcomes, I believe, allow us to impact all three of those areas.
A few years ago, in about 2012, I and several of my colleagues realized we're really missing a dimension in the clinic of what happens to patients. If I see an arthritis patient, say with rheumatoid arthritis 4 or 5 times a year, patients are living their lives for the other 355 or 60 days of the year, and I don't really know what's happening to them. And so in about 2012, I and a few colleagues here, James Willig, Monika Safford, and others, developed a tablet app that runs on an iPad that would capture patient-reported outcomes, or really just how patients are doing, in a quantitative way. That's really relevant in a rheumatology field because we have this emerging concept of what's called treat to target. The idea is that we should be quantifying or measuring your arthritis, in this case rheumatoid arthritis. There's a lot of trial data out there and even some real-world studies showing that if you quantify RA, or rheumatoid arthritis, disease activity, and you change medicines to get people into low disease activity or into clinical remission, the patient outcomes are better. The problem is that in the rheumatology field, we don't often quantify things. In endocrinology, the endocrinologist may measure hemoglobin A1C, or we measure a blood pressure or your cholesterol, and then we make treatment changes in relation to those tests. This is a very new paradigm shift for us in rheumatology. So we developed a tablet app that we're able to do this in the clinic. And we've been using that now for a couple years in the rheumatology clinic. In fact, this is just one example of part of a medicine endeavor where we are collecting information in lots of clinics. So for example, in palliative care or in one of our infectious disease clinics, we're tracking how people are doing. That could be anything from how bad your arthritis is doing to what kind of pain are you in, what's your fatigue level like. So this is a direct application of technology really impacting what's going on for people in a clinic setting. The limitation, though, is in fact just that. It's in a clinic setting, but patients live their lives mostly out of a clinic setting. So in the year 2013, we decided that we're going to embark on a new pilot project to be able to capture patients' data from them directly, not just while they show up in clinic several times a year, but in fact at home, using technology that they already have, probably in their pocket if it's a smartphone or on the internet if they have internet access, and about 2/3 to 80% now of people do in the United States. So we have the ability to track how people are able to do over time.
The part of the program that I'd like to describe to you today is called the Patient-Activated Learning System. And this is a system that we are developing based on the work that we're doing in the Alabama Black Belt, focusing on medication adherence and diabetes. And what we've done for the past year is talk to a lot of community members about what makes it difficult for them to take medications. Medication adherence is an enormous problem in medicine. It's estimated to cost $290 billion a year. Because about half of people who are recommended to take medications such as diabetes medications for chronic disease end up not taking it the way it's prescribed. And that ends up in cardiovascular events, stroke, heart attack, end-stage renal disease, and a whole host of bad outcomes that one would think patients would want to try to avoid. So it's quite puzzling to physicians why patients wouldn't want to take the medications that we recommend. So that was really what we set out to do. And what we're learning is that patients really do want a lot of information. But the painful thing for us to hear is that they may not want to get it from us or in the doctor's office. Many patients find the office visit a little terrifying because they're afraid what the doctor is going to tell them, bad news, more tests. So it's not exactly a teachable moment, which makes a lot of sense when you hear that, but I think for a lot of physicians, we want to try to provide education to our patients. The other piece that we're finding, which is widely known but really not very well addressed, is the number of misperceptions that people have about diseases and about medications and about the role of the medications. So what ends up happening, because people are not getting the information that they need, they're looking for it wherever they can find it, and they often get that information from friends, neighbors, family members, and worst of all, possibly ads on TV. So what we are doing is creating something that we're calling the Patient-Activated Learning System, or the PALS, which is designed to be an online web-based platform that is a single place where you can get all the information that you want about your health, about diseases, and about medications. Right now, if you go online, there are a plethora of websites that provide information for patients, so why do we need another one? One of the problems that people express is that there's a lot of information that's all over the place. So if you have a particular question, it's very hard to find the answer, and that's very frustrating. So we know that right now patient education materials are a little on the boring side. They're not very engaging to patients. Probably patients wouldn't want to read them more than once, and many of them probably don't read through the entire thing even that one time. So what we want to do, in addition to make this a one-stop shop that answers your questions, is also to use principles of something that's being called edutainment, so a combination of education and entertainment, so that the segments are very short with very clear objectives. They're designed to answer specific questions, and they're very engaging. So there are several online educational programs that are not health-related that we're using as models to sort of revolutionize the way patients receive education about health and their health conditions.